This video made possible by Killer Visual Strategies. Visit killervisualstrategies.com.
You know, this is about interoperability, is in the title, but it's really first and foremost about how we as people, as individuals, and our loved ones, our kids, our parents, have access to our records and our information. You know, one of the great challenges of this industry is, and in many parts because of the fee-for-service structure and incentives, is such that even if you try to access your records, despite the fact that there's over 96% digital availability of your data, whether it's your drugs, your notes, the physician notes, the longitudinal health records, the images, all of those are sort of locked into silos. I think last time I checked, there's about 6,000 hospitals in the United States, 230,000 or so physician offices. There's about 800 health plans and insurance companies. And all of them, with the best of intentions, have built their own legacy infrastructure. You know, some of them are under, Epic installations, Cerners. In the case of a company like Regence, it's a facets backbone that manages our claims adjudications. And all of them have built these backbones, tragically, not to serve you as people or you as a patient, but really to serve their own purposes. So in the case of I'll speak for myself, in the case of a health plan, our legacy backbone, and again, this is all the best of intentions. It was not meant to make it difficult for anyone, but it is the way the incentives work. So in the case of health plans, our core IT infrastructure is a claims adjudication backbone, which is all about managing and paying claims, right? And ultimately managing risk for individuals in the context of their needs. Is the presentation on? Oh, here we go. Great. And paying their claims. And ultimately managing risk and controlling that hospitals and physician offices and others, are following certain guidelines and constraints. In the case of a health system or a hospital, their backbones are really all about registering a patient at the moment of an episode. It's about tracking that patient. In one of my past lives, I owned an electronic health record product, and we actually called it an enterprise orders product. It was not a patient-centric product to serve longitudinal health record to achieve better clinical or patient outcomes. It was a product to be able to register a patient, to record every service and codify every service that was being delivered for that patient, capture their data, for sure, and then ultimately to bill the insurance company and discharge the individual. If you look at employer systems, of course, which many of us get our insurance from, all of those systems are, again, strictly limited to the status of the individual as an employee, not the status of the individual as a person who has a beginning of life to an end of life. And so you have this enormous infrastructure with this enormous complexity. Even if some of the brand names of the systems are the same, for example, on the clinical side, it's dominated by Epic and Cerner. On the insurance side, it's dominated by companies like NASCO and Facets. And there's many others, but those are the big ones. Every installation and implementation of those systems is different. So 6,000 hospitals, 800 health plans, 230,000 physician offices. Each one of those has a different identity for you. Each one of those has part of your records in it. And I'm not even speaking of the pharmacies, the drug companies, the labs, et cetera. So an enormous amount of complexity. The other dimension that's tough here is that, and this is something that's not always known by those who are not in the healthcare industry, is that the Office of Civil Rights that wrote the HIPAA rules has specifically codified, and this is not a new thing, this has been the law for a long time, is that your health records belong to you. I mean, they actually belong to us as people, not as healthcare professionals. They don't belong to the hospital. They certainly don't belong to Regence. They don't belong to the labs. They belong to you as an individual. And you have a right to those records. And the law states that we, as healthcare participants, any one of the people in this sort of solar system of stakeholders in the healthcare system, have a responsibility to make them available to you in a private, trusted, portable way. Now, for those of you who've tried, I think you probably have discovered that it is incredibly difficult. And there's a whole series of what we call now sort of information blocking sort of attempts to make it difficult for you. Some argue that it's difficult to download it and make it available. Some argue that you may not be equipped to make the right decisions and to protect that information. I mean, there's a million excuses. And ultimately, they all prevent you as an individual to not only have access to those records at any one of those individual stakeholders, but they prevent you from actually aggregating these records and creating a portable lifetime representation or record of your health life, right? Whether you live in Seattle, you live in Baltimore, you live in New York City, and of course if you move, which most of us do, then the ability to do that is incredibly complex. And this is really what interoperability is all about. The other trend, and I know some of this has been touched on by some of the other presenters at this conference, is that all of us, and not just millennials, we like to talk about millennials, but I think all of us, without exception, outside of healthcare, are used to a level of frictionless experiences, right, that is hard to imagine. I think it's totally legitimate to expect, but hard to imagine existing in healthcare. So whether it's the overused examples of Netflix or Uber or Lyft, Airbnb, or any one of these applications that we all love and use every single day without thinking about it outside of healthcare, the expectation at the end of the day is that we should be able to do that in healthcare. The problem is to be able to execute in that in healthcare, you have to have access to data. All of these solutions that are transformational and have completely upended the experience in those industries are based on one thing, is they know who you are, they have access to your data because you've given them permission to access your data and to retain your data, and they apply data sciences, predictive, prescriptive technologies from augmented intelligence to others, right, to be able to develop solutions that are tailored to whatever your requirements are, whether it's a geographical location, whether it's moment in time, whether it's a trip that you're taking on vacation to Italy or whatever it may be. Well, in healthcare, the dimensions of complexity are even more complex and even more sophisticated and even more sensitive to your personal and geographical and emotional needs. We should be able to provide you with that same level of guidance. But if we cannot access the data, if we cannot aggregate it, deconstruct it, and relink it in ways that are relevant to you as a person, regardless of whether you're interacting with a physician, whether you're home or you're traveling, or whether, for example, you're trying to take care of your ailing mother or your partner or whoever it might be, that data needs to be accessible, assuming that you have permission to use it. And when it is accessible, it shouldn't be just a data dump, right, which if you're lucky is what you're going to get today, but actually it should be something that is context-sensitive, personalized, and presenting you with risk factors, risk profiles that are personalized to you at the moment you need it, when you want it, and all the stuff that's not relevant at that particular moment is hidden from you. This is what we expect outside of healthcare. We should have that in healthcare as well. The other good news is that it's not a technology problem anymore. Now, technology is a problem in the sense of this incredibly complex legacy infrastructure that the HITECH Act, you could argue, has helped by getting us to over 95% penetration of digital infrastructures, but also has hurt our ability to leverage technology because we have a level of complexity now of systems across the nation that we've never had before. I still believe it's a good thing that we went through the HITECH Act, that we've gotten to over 95, 96% penetration of electronic health records and claims adjudication and so on. The danger right now is that all these systems still retain proprietary interfaces, batch bulk data exchanges, usually exclusively between provider to provider or health system to health system, sometimes in the context of value-based contracts from health system to payer, very rarely from health system or from payer or health plan to individual, right? And this is where we need to break that, and this is the big threshold. And I believe, among a number of other people, and what's exciting is that I think this is becoming not necessarily a dominant group in numbers, but it's become a dominant group, let's say, in the volume and the visibility of these individuals, certainly their voice, is that we are reaching, if not crossing, the tipping point where the industry is willing to adopt standards such as the FHIR HL7 FHIR standards, not only in the context of ensuring that an individual can access their records, such as the use case I mentioned earlier, but also that providers and payers will actually exchange data together to be able to make it easier for an individual to get the best care at the highest value. I always want to give credit to the government. We like to beat up the government and the Health and Human Services Department, the OCR, CMS. But I will say, in the world of making data free, in the world of making the portability clause of HIPAA a reality, the Center for Medicare and Medicaid Services has really done some exceptional work. And they were the first, in the context of the Blue Button 2.0 instance and standard, to adopt FHIR standards and to make available to, I believe, a little bit over 43 million beneficiaries, Medicare beneficiaries, direct access to that Blue Button 2.0 API and the ability to download up to 4 years of clinical history, right, to the, claims history, I should say, to those individuals, right? They were the first, so it is possible. 43 million is a material segment of the population. And what's exciting is that they're continuing to push. As some of you may have heard in February, for those of you who attended HIMSS and might have seen some of the news coverage after that, CMS, Seema Verma at CMS, and the ONC announced new rules, which at the time stated January 1, 2020, to make it a rule that all payers and providers would adopt HL7 FHIR APIs to make data available according to two use cases. One, the direct right of an individual to access their record directly through an API, or to give permission to a third party, who is not, in most cases, a clinical institution, to actually access those records on their behalf and then to manage them, visualize them in ways that are relevant to the individual, presumably in a very innovative way. Or in the context of a group called the Da Vinci Project, which is also another HL7 sponsored group, which is now about enabling value-based care, right? Where the hospital and the insurance company have a shared incentive, right, to provide better value, lower cost care with better outcomes to individuals. And in that case, enabling the collaboration between hospitals and insurance companies to actually share data, which sounds pretty reasonable if you're a patient or a consumer, but sadly or tragically is kind of a rare thing in the old fee-for-service world. But the nice thing is that value-based care makes it very possible. The government has been excellent. The other thing I like to say here, and the news these days only gets worse, and you might gather my own political opinions, but this administration, this is one of the few truly bipartisan topics in Washington, D.C. today. I wish the news would cover this, but there is actually 100% alignment in actually ensuring that an individual gets access to their records and make it as portable to ultimately sponsor and make it easier for third parties to innovate in this space. I've mentioned Da Vinci and Karen. I'll certainly say that Regence as a health plan, and I'd say there's about a dozen organizations out there, particularly payers. They're actually associated to you can see the full list following a conference that took place at the White House Blue Button 2.0 Developer Conference over the summer, that actually signed up to embrace these standards, not as a way of competitively increasing our differentiation by controlling and holding back the data, but actually by opening these up, right, and making this available and becoming organizations that are actually driving to push that tipping point to make the free exchange of data at the benefit of the individual, independent of the institutions that are entrusted to manage that data, make it free, make it available, and do it by the end of this year. So we are very excited about it. I suspect the rule will probably become law January 1, 21, rather than 20, but I think it is very exciting, and we're moving in that direction. So my belief is we are on the cusp. We have some great partnerships. Actually, I'll speak in, Regence operates in Washington State, Oregon, Utah, and Idaho. We have some great partnerships with some clinical leaders in this region with, Multicare based out of Tacoma, OHSU in Portland. We have some great work also with Providence. And a lot of these, what we're hoping is we're going to just demonstrate through proof of concepts with them sort of the incredible transformational value of being able to care in more efficient, quasi-real-time way through APIs, individuals, rather than perhaps the old sort of controlled and rigid process of the past. So with that, I'll stop here because I know I'm out of time, but I just wanted to tee up some of these But these are extraordinarily exciting times, and it's going to take a group of like-minded stakeholders in the industry who not only have the hope for a better future for individuals, not only have the courage to actually put their current legacy business models on the line, right? To actually embrace the innovation that third parties who are trying to disrupt the industry, and to be able to disrupt industry need to actually have access to this data to provide deeply personal, quasi-real-time, proactive solutions and access to care at a cost-effective level, right, for us to be able to disrupt this industry. So we are enthusiastic advocates and champion of that, and I'm hoping some of you in this room, support it and potentially join us. So thank you for that.